there has been such a there has been such a great participation. We encourage you to continue to watch these as we organize them. Really, it's been an honor to serve as the CME chairman. Today, we're joined by Dr. Arsine Kalfayan, who's also a member of our CME committee, who will be helping moderate this session. Also, next week, we have several webinars that are coming up, both on Monday and Tuesday. Dr. Sherwin Hariri will be presenting on Monday on aspects of quality and testing as it pertains to COVID-19. And on Tuesday, June 16th, I believe, we have a series of speakers in collaboration with the Armenian Bar Association. And we'll be talking about how we will be working together and what are some of the things, the new challenges in the workplace in this era of COVID-19. With that, I'd like to introduce our speaker tonight. Our speaker who's known to many of you. He is one of our board members, Dr. Boris Bagdasarian. Dr. Bagdasarian completed his undergraduate studies at Cal State University and the University of Southern California. His medical school training was conducted at the Western University of Health Sciences, where he graduated magna cum laude. Dr. Bagdasarian was chief resident in internal medicine at White Memorial Medical Center and continued his specialty in hematology, oncology, and bone marrow transplantation at the renowned City of Hope National Medical Center and UCLA, where he was chief fellow. He currently serves as parliamentarian and has served as vice president and president of the Armenian American Medical Society. He's the previous president of the Los Angeles County Medical Association, District 4, currently a delegate for the California Medical Association. He's a member of the Board of Governors at Adventist Health Glendale. He was recognized among the top oncologists in the US by the Scientific Research Council of America. Dr. Bagdasarian is the former associate professor at University of Southern California, Department of Hematology and Oncology. Currently, he's the managing partner of the Los Angeles Cancer Network. He was appointed to the list of super doctors featured in Los Angeles Magazine every year since 2015. With that, Dr. Bagdasarian, who's a dear friend, I know him as Boris, I would like to invite you now to go ahead and take over this platform. Please go ahead and unmute yourself. And Dr. Bagdasarian is going to talk to us about various aspects of the oncology as it pertains to COVID-19. Thank you, Dr. Bagdasarian.
Thank you, Dr. Sepilian. I want to thank the Armenian Medical Society for this honor and privilege, and a special thanks to Viken for all the phenomenal work that he has done for a very long time in educating our community. It's been 10 years, if not longer, and for his dedication during this pandemic in putting together this webinar series. God bless you. And without further ado, I wanted to discuss the important impact that the pandemia has had on cancer care. And this talk is independent of any pharmaceutical endorsement. Let's see. Okay. There we go. Okay. So as an introduction, the coronavirus, as you all know, is now regarded as a SARS-CoV-2 virus. It's in that family of SARS causing respiratory failure. And this virus is highly contagious, as we all know, and its impact on our cancer patients has been quite significant, as it has on, throughout the United States and the world. There have been delays in diagnosis, in treatments that require elective surgeries, radiation and chemotherapy. However, we've emphasized the great importance, as has the American Society of Clinical Oncology and the NCCN, that if there's anything that is life-threatening that needs to be immediately addressed. And you know, to get the message across to all the patients has been very difficult, especially in the first several months. And of course, with the inadequate supplies, there was this issue with the PPEs. We all remember the horrific situation in New York, and with the lack of supplies, and we were worried that the same thing might be taking place in California, but thank God it hasn't gotten to that, and never will. This slide briefly goes over some of the clinical presentations. I apologize for the picture. We'll go over that now, but majority will present with fevers if they are going to be symptomatic. So fevers, dry cough, which then can progress into a more intense type of pulmonary infections that can lead to hospitalizations, sore throat, loss of taste. And interestingly, in cancer patients, pernio, which was going to be demonstrated in the picture that somehow got blacked out, revealed erythematous changes within the digits, not only in the fingertips, but on the toes. They could be at times nodular. And we've seen more of these presentations in patients with hematological malignancies, and we'll soon find out, you know, the pathophysiology behind that aspect. So then question comes up, you know, how can I protect myself? So is there something special that a cancer patient needs to do in terms of protecting he or she? Pretty much the CDC came out with the best guidelines, and they're listed here on the slide. And as you all know, quarantine and isolation for our highly immunosuppressed patients is mandatory. In addition to hand washing, 20 seconds is the magic time. With, if you can go to 20, 30 seconds with warm to hot water. Does have to be antibacterial soap? Not necessarily, because the use of it can also lead to drying of the skin. And same goes for just relying on alcohol-based hand sanitizer. You want to avoid touching your face. As you know, the virus is highly contagious, and one of the main ways of transmission is by transferring the virus from your hands to your face and mouth. So with the use of masks, that has been less and less. People are becoming more and more in tune of how important it is to avoid touching their face. The same thing goes for coughing and sneezing. Please respect the people surrounding you and attempt to sneeze or cough in your hand or in your elbow. Shaking hands, unfortunately, has been is a thing of the past now. Maybe we might get back to that, and we're coming up with innovative ways in greeting with high fives and elbows and using our ankles nowadays. But avoiding crowds is mandatory, and just try to stay put and not travel unless absolutely necessary. And the same goes for our caregivers. Our caregivers are one of the most important people, whether it's a family member or whether it's a hired nurse. They need to abide the important rules. Avoid crowds. On weekends, if you're invited to somewhere, you have to be a responsible person, that you're taking care of these highly susceptible individuals. Sterilization of their environment where they live is important, especially if that individual is coming and going. The shoes are important. Maybe leaving the shoes at the front door, wearing a different set of shoes or slippers that stay in the house. Washing hands, of course, and if you're going to go out, whether you're the patient or the caregiver, to shop, wear a mask, wear gloves, remove your gloves when you're placing the food in the vehicle to transport, and then reglove and take the food in and do your process of sterilization. So this is something that over the past several months, people have been mastering, and it's important to continue to do so. We all know that cancer is a condition that can increase the risk of infection, and most susceptible are those who have hematologic malignancies, especially if you have bone marrow infiltration, leukemic patients, whether it's chronic or acute leukemia, patients that are with advanced disease. You know, most common cause of death in individuals with advanced cancer is dying of infection. So the body has a unique way of suppressing our immunity in an attempt to protect itself from the immune system in neutralizing, which we'll go over once we get to a couple slides downstream. But the hematologic malignancies and lung cancers really pose the highest risk of death in patients with COVID. So when you look at this analysis of 5,600 patients over 5 weeks in New York, we see that about 6% of those patients had cancer. And the ones that were most susceptible were the individuals between 66 and 80. And a fair number of those that ended up becoming intubated, go through the cytochrome storm and not make it. So they had a higher case fatality ratio, CFR, and the highest mortality, as I mentioned, was lung cancer and hematologic malignancies. So generally, the risk of death is about threefold compared to the general population. And same holds for the patients in Europe, the data collected from Spain and Italy and Wuhan. And there are a higher incidence of intubation and succumbing to the virus. So body has a unique way of protection. We all know that an intact integument is important. Our skin is a key barrier. Individuals with psoriasis or chronic dermatologic conditions that is a challenge to begin with, but if you have metastatic lesions on the skin, which is not a very common thing, but it certainly can be a source of how the virus can enter. But it's important to also mention our mucous membranes. You know, if we have patients who are going through head and neck cancer, radiation and chemotherapy, chemotherapy alone can cause the increased risk of stomatitis, and that could certainly be a risk factor in such individuals. Nutrition, we've been talking about this for decades, how important nutrition is. You know, patients who are poorly nourished will not respond well to chemotherapeutic agents. Many studies have shown that the performance status of an individual is reflective not only on the nutrition, but their physical activity. Nutrients are key in ensuring that the transport proteins like albumin, which majority of these drugs are going to be, chemo agents are going to bind to be not only activated to a prodrug, but to be metabolized. And if the albumin levels are low, the chemo is either not going to work well or stay in the system for long periods of time and cause increased toxicities. The same goes for patients who need to go through elective surgeries. We generally need to make sure that their immune system, or rather their nutrition, is optimal to improve their immune system to recover from the surgery. And so we do everything right up front as cancer specialists in our practice to go into great details about the importance of nutrition in not only patients who have stage 4 disease or are going to be chronically managed, but our patients who have curable disease. That's vital. Managing their nausea, improving their appetite. If there's a need to provide a feeding tube before embarking on head and neck cancer, where it's inevitable that they're going to have issues with swallowing and nutrition, these things need to be done, you know, right off the bat, and utilization of nutritionists is very important. The other major question, you know, is screening. We've had a major drop off in cancer screening. There was several important articles, one of which was in the Lancet Oncology not too long ago. There were several discussions at ASCO, which is the American Society of Clinical Oncology, which took place about a week and a half ago in discussing cancer screening. And we feel that this is going to be an issue throughout the rest of the year. It might upstage from a stage 0 to stage 1, stage 1 to stage 2 in breast cancer, colon cancer screening. But generally, I think it's vital, especially if you have hereditary breast cancer or colon cancers, Lynch syndrome, etc., BRCA mutations. These patients need to be screened because any delays could be extremely detrimental. So as things are opening up and hospitals and diagnostic centers are stepping up like we have in pre-screening, screening, and ensuring that the environment is in a very safe and well thought out system to protect our patients, these screenings will increase, and especially colonoscopies and so forth. So I think the importance of screening patients with for COVID is vital here, especially if a patient is going to be going through a very compromising type of treatment, which we'll go over in the next slide. But if they're symptomatic, so typically what we do is we pre-screen patients, we call them the night before, we ask a whole series of questions about symptoms. Are they coughing, having fever, sore throat, any signs or symptoms suggestive of infection? Have they been exposed to anybody that has been exposed to COVID? And these individuals then are screened. We send a team out to their home to do the testing, and within 12 to 24 hours we have the results for which the patient will then be either directed back to our office or to be placed in quarantine and using our team with the PCPs, etc. Now, a second wave of hospitalizations started taking place, which is non-COVID related. And that's in individuals who are going in with congestive heart failure, patients waiting too long with symptoms of chest pain, and the same goes for our cancer patients. So this is so important to be communicating with our patients through telemedicine and discussing the symptoms they're having. They might be having a pulmonary embolism. There may be lymphangitic spread, could be COPD exacerbation. So these are very important things that as an oncologist, working as a team to ensure the safety and health of our patients is vital. Pretty much every patient who gets exposed to somebody with COVID will get screened. People automatically who are going to be hospitalized are screened. For instance, at Glendale Adventist, we have 2 towers. Patients who, whether they are positive or negative for COVID, will go to the West Tower. And then after 2 negative screens will be transferred to the East Tower, where they're all COVID negative, and that's the ward where our oncology patients are. Elective surgeries, colonoscopies, of course, all will need to be screened. And then as far as I mentioned a couple minutes ago, people who are going to go through aggressive types of chemotherapy, you really want to make sure whether they're symptomatic or not to be screened for COVID, especially the asymptomatic patients who will be treated for leukemias, acute leukemias, intermediate or high-grade lymphomas, dose dense chemos, myelosuppressing, very myelosuppressing types of chemotherapeutics to reduce risk of catastrophes. We all know that surgery itself has an ability to weaken our immune system, so that hence the delay and anesthesia. There have been tons of studies over the past several decades that has shown that the anesthesia to some degree or another will cause immunosuppression. Now, with the newer generation agents, not as common. Surgery can lead to breaking the skin, dry mucous membranes, can certainly increase the risk of infection. So post-op patients, oral care is extremely important there. So the duration of the surgery, the age of the individual, if they have chronic comorbidities, diabetics, cardiovascular disease, of course, it's a compounded effect, right? Their nutritional status, if somebody's heavily been pre-treated with chemotherapy, they already have, a staggering immune system where the surgery can certainly make things worse. Radiation, we know, can cause leukopenias, especially for those who are getting radiation to the pelvis. These are patients undergoing neoadjuvant chemotherapy for rectal cancer, patients going through radiation therapy for cervical cancer, uterine cancer, bladder cancer. So we have to be very careful. Of course, risk to benefits ratio there. Total body irradiation is a type of radiation that we typically utilize in patients who are undergoing bone marrow transplantation. And we'll talk about that in the next couple of slides and how those have been delayed in the low intermediate risks. Chemo, as we know, is the most myelosuppressing, and the neutropenia is a common thing here. So the type of chemo utilized, there are some who are receiving low-dose weekly chemotherapies for advanced disease for which the risk is there, but nothing significant. For those who had intermediate risk of neutropenic fevers, we generally are, in the past, we used to wait for the blood counts to return a week later, but now the NCCN and American Society of Clinical Oncology has made the recommendation to maybe reconsider using these growth factors, and the threshold for utilization of these growth factors like Neupogen, Zarxio, Neulasta has dropped to reduce the risks of infection, of course. So immunotherapy is a very common type of treatment that we utilize. It's exploded in the past several years, where it went from lung cancer, now we're using it in pretty much almost every type of disease. And immunotherapy is unique in that the body finds a way to inactivate our and weaken our immune system to allow it to proliferate and to thrive. And so there's been questions out there, does immunotherapy weaken our immune system in increasing the risk of infection? So let's go over a couple of slides and we'll discuss that. The slide below clearly shows the mechanism in a simple way, where the PDL molecule, which is referred to as a programmed death ligand, binds to a receptor on the T cell, which inactivates the T cell, and thus not allowing the T cell to perform its functions. The American Society of Clinical Oncology is not aware of any specific data that really shows that increases our risk of infection and death. And here's another slide that shows, my apologies, let me get back to that. That shows that the immune checkpoint inhibitors, as they saturate these receptors, allows these T cells to summon and bring in important cells that are in a concerted effort involved in a cascade to neutralize tumor cells and, of course, other infectious agents. I did some research and discovered the largest study with the use of immunotherapy in determining if there's an increased risk of infection. And this was a 4-year study conducted on about 740 patients at the renowned Sloan Kettering Cancer Center in New York. And about 90% of these patients, they all had melanoma, 90% of these patients received immunotherapy, and a smaller percentage had some chemo. But you see down below that the number of cases of viral associated infections was quite small. And in fact, the authors of the study concluded that the immunotherapy, contrary to chemotherapeutic agents, really did not increase the risk as high as they thought they would. And it may offer some protection against other infections. So let's now go over the cancer's type-specific guidance, and this is the risk stratification now that has been accepted by the National Comprehensive Cancer Network Guideline, the NCCN, and ASCO, the American Society of Clinical Oncology. There's no international guidance or set of rules, but this is pretty much the breakdown of what we are doing here in the US. So for low-risk patients, this is a situation where you can delay the treatments for 3 months or longer, or generally for patients who have slow-growing tumors, non-melanoma skin cancers, squamous cell cancers, basal cell cancers. These things can be delayed because the treatments are quite effective, and surgery is the mainstay of treatment. Slow-growing breast cancers that express ERPR, estrogen, progesterone at a high level, which are HER2 negative. In locally advanced patients with big breast tumors, even in those category individuals, we've done neoadjuvant treatment with anti-hormonal therapy to shrink the tumor. So this gives the individual time, even in the early stage, for delaying the lumpectomy or mastectomy. Similarly for CLL, we have wonderful oral conjurers. We try to do our best to avoid IV drugs if possible, and to reduce the need for these patients to come in and out of the office. So if there's some oral conjurers or have an oral medication that has the same efficacy, then that's the way to go. As far as the intermediate risk individuals, the surgery can be delayed in patients with Gleason 7, 8, with the use of GnRH analogs like Lupron, plus or minus anti-androgen therapy to keep the disease under control, to lower the PSA. Same thing for colon cancer without any obstruction, but that's one disease you can't wait too long because of risk of dissemination. I wouldn't wait more than 4 to 6 weeks. Low risk melanomas, most are high risk. And the same goes for radiation for, again, similar prostate cancer patients and certain breast cancers. Excuse me. So intermediate risk patients are, generally patients who are going through metastatic, for their metastatic disease. Yeah, the doctors have to individualize what they're doing there to delay only if there's a marked increased risk of infection, and if they're in a location where the risk is very high, like in New York, for instance. Pardon me. So most of our patients, we have not delayed the treatments. We have recommended to switch them from IV to oral if that exists, or from a full dose regimen every 3 weeks to low dose weekly if possible. And of course, you got the high risk category of individuals such as lung cancer. Lung cancer can't wait. If they have localized disease, they need to go through surgery. High risk colon cancer patients, endometrial, pancreatics, of course, if they have resectable, curable metastatic lesions, proceed with that. Bladder cancers, of course, sarcomas need immediate attention with surgery. And then patients with high-risk lung cancer and post-obstructive pneumonia patients, SVC syndrome, those can't be delayed. And of course, the high-risk category of individuals listed for chemo. Then comes stem cell transplants. The stem cell transplant is typically used for patients who have hematologic malignancies. And of course, we're also using CAR T, but stem cells have been delayed in the low to intermediate risk individuals. We'll go over the breakdown, but these patients go through a high dose chemotherapy plus or minus total body irradiation. So all of their stem cells get wiped out, and hence pretty much their defenses are gone. So the two major institutions that set guidelines were Mayo Clinic and Fred Hutch, which is in Seattle, is one of the best centers of excellence for bone marrow transplant up in Seattle. And so we have two types of transplants. We have allogenic transplants and autologous transplants. Allogenic is when you're using the donor's stem cells, and hence, you're running the risk of graft versus host disease and immunosuppression with oral medication, which is going to further increase your risk. So patients with intermediate risk AML, ALL with multi-drug resistant negative, Philadelphia chromosome negative, some patients with MDS and myelofibrosis, this can be delayed. However, patients with high-risk disease, once they have gone into a complete remission, transplant is recommended. Same goes for patients who had relapse and went into remission. If there's a donor, you got to transplant these patients. As far as autologous, most of these can be delayed. I have a fair number of myeloma patients that I'm following now that were due for transplant that have been delayed. We have them on maintenance agents, and thank goodness so far their disease is well controlled. We're doing bone marrows a little more often than we should. So the transplants that were supposed to take place in April and May are now moved towards August and September. Same goes for autoimmune disease, etc. In terms of the supportive care, according to ASCO, there's really no role for prophylactic antiviral agents. In fact, some such as hydroxychloroquine has been found to be high risk. So we don't prescribe or recommend these, nor for non-cancer patients. Generally, we like to recommend to flush the portacath every 4 weeks or so, or if they're coming in for treatment every 2 to 3 weeks or so, we get the port flushed then. But if they're in the maintenance phase or patients who are being managed, we recommend for them to come in less often, like every 3 weeks. Transfusions, only if they're really symptomatic they need transfusions, such as hemoglobin's less than 7. For some who have congestive heart failure or coronary disease, that might be a much higher. And as I mentioned earlier, the use of growth factors, the threshold has dropped. So it's really important to try to limit the amount of visits to and from the office, visits in and out of the hospital, transfusion centers, and do your best to reduce the risk of neutropenia with utilization of growth factors. The question sometimes comes up and people call and ask, hey, can I get COVID from blood transfusion? Well, according to the American Red Cross and the American Society of Hematology, there's no such evidence that the virus has been transmitted. Of course, other viruses such as HIV and hepatitis, certainly Epstein-Barr, CMV, but thus far COVID has not been identified. What has happened is that we have a significant shortage in blood, and especially platelets. So it's important that as physicians and individuals in the health industry, please go and encourage your family members and patients to donate, because it's vital that we replace the lost. The blood banks are really at a major shortage right now. And briefly, let's go over some of the hematologic manifestations. We pretty much know about the cytopenias. Lymphopenia is very common, as it is with many viral infections, with influenza and a variety of other SARS types of viri. Thrombocytopenia as well, but the degree of the thrombocytopenia is very important, which can lead to a DIC, which we will talk about. So the platelet count in a large study that was conducted in a meta-analysis, 9 studies of 1,800 patients roughly. There was a correlation between the platelet count and whether these patients had severe manifestations or not. And so the main manifestation is the progression into DIC. I'm sure you've heard of the incidence of DIC. That's a correlation with the cytochrome storm. A vast majority of people who develop DIC have the cytochrome storm and develop the pulmonary symptoms. And so another retrospective study out of Wuhan looked at the data of about 200 patients, and non-survivors had significantly higher D-dimers, higher fibrin split products, and coagulopathies versus those who did not manifest itself or manifest a DIC. And a large number of these patients, unlike most DIC cases, led to thrombosis. And because of that, microemboli has been found in a large number of patients, and it's pretty much standard across the country now to prophylactically start these patients on anticoagulation. Asymptomatic patients can develop antiphospholipid syndrome. Question is, did these people have pre-existing antiphospholipid syndrome where the virus had unmasked that, which is possible, but we will determine that in the next year or so once more data. But it's standard of care to start patients on anticoagulation if they're identified with thrombotic events. Then you're not going to use the prophylactic doses of the low molecular weight heparin. You're going to give the full dose. If they have renal failure, you're going to use heparin. If they have heparin-induced thrombocytopenia, you can consider using argatroban or fondaparinux. Mental health issues, it's bad enough that these cancer patients are dealing with a great deal of anxiety and stress from their disease. And on top of that, now they have this additional compounded problem that they're facing with the risk of developing COVID. And many, out of fear, were in isolation. They're isolated not only from going to doctor's offices and getting their treatments, but their family members. And that also exists with non-cancer patients. And the amount of prescriptions that have been prescribed for anxiolytics and antidepressants has gone through the roof. I was talking to my colleague who's a psychiatrist. He's been busier than ever during these COVID times, which is very understandable. So as oncologists, we always wear many hats. And as an oncologist, as a nutritionist, as a pain management expert, but more importantly, our role as a psychiatrist, a psychologist has been at a higher level, especially now. So, reassuring these patients, getting on the phone with them, getting on Zoom conferences with them is vital to reassure them and to create a system in place that creates comfort. We've perfected the art of our office in terms of pre-screening, screening. Everybody in the waiting room pretty much is distanced. Everything is cleansed after the patient walks in. No visitors are allowed into the infusion room. The infusion chairs are separated and cleansed day in, day out. And so with these systems in place, you at times can share the videos of the place, and they see this, and same thing goes for major cancer centers and hospitals. That type of reassurance goes a very long way for these people to provide security for them. So in summary, the delivery of cancer care has been very, very challenging. God willing, soon we'll have a vaccine. There's many discussions that it may be as early as December. Some say as late rather as March or April. But it's extremely important that our immunocompromised patients follow the CDC guidelines. Family members, caregivers are very in tune with these things, and it's easy to drop your shields and say, okay, I'm tired of this, but it's vital. It's, we instill this in all our cancer patients, even before the COVID. And many will continue to follow those guidelines. And, do the testing for those that require to be tested, the pre-screening. There's no universally accepted guideline as to when immunosuppressive cancer therapies can be safely restarted after a COVID diagnosis. We generally like to wait at least, a month or so. We retest them to make sure that they're not going to activate, be COVID positive, because there's a risk, obviously. So clinical judgment and individualized decision-making that balance is extremely important for all our patients. So that concludes my my talk, and I'm open to any questions now.
Thank you, Dr. Bagdasarian. I'd like to now invite Dr. Garni Barkhudarian and Dr. Arsenek Kalfayan, who will take over and moderate the Q&A session.
Hi, Garni.
Hi, Dr. Bagdasarian.
Hi, my friend. How are you? Good to see you.
Good to see you as well.
Dr. Bagdasarian, thank you very much for really clearly identifying all the challenges and addressing them and sharing your skills and strategies to best take care of our patients.
Thank you. Thank you.
So, Dr. Bagdasarian, this was a very nice overview of all of the oncological and hematological issues that our patients face day to day with regards to the COVID crisis and other types of situations. And, myself dealing with lots of cancer patients, we've certainly seen our fair share of challenges as well. And not only the patient's own health, but the delivery of care and some of the issues we've had. Just off the bat, just as you had mentioned earlier, I was wondering how things are right now in the Adventist Health Center with regards to triage of care. We've only recently reopened 2 elective cases, and patients are just starting to come back in, which has already started to displace some of the capacity we have. And we're wondering how that is in your practice and your patients in the hospital that you work at.
Yes. As of, I would say, about 10 to 14 days ago, it pretty much opened up. So a lot of the elective surgeries are taking place. In fact, some of the breast surgeons were doing like 7 breast procedures in one day, so they're trying to catch up. They're catching up with, the colon cancer surgeries, the breast surgeries. Of course, the high risks did take place. A lot of those were, hospitalized cases with bowel obstruction. I mean, emergencies, right? Cord compression for patients with metastases to the spine, unfortunate cases. Those things could never, be delayed. But the elective stuff is picking up. We're seeing more people going to the diagnostic centers for their mammography. They're going for their colonoscopies. Pretty much the patients that require hospitalization or any type of procedure will have to be screened for COVID. So colonoscopy surgeries, and pretty much all those patients do go through the pre-screen and then the obvious testing and so forth. So it's picking up. Surgeons are working extra hours now, and the ORs are going into way beyond midnight now, and to be able to catch up. So yes, it's opening up.
Yeah, that's good to hear, and I'm glad that the physicians and nurses and caregivers are staying safe. And we've also implemented a mandatory COVID test, and in some cases 2 negative COVID tests, as the sensitivity of that test is still questionable, especially for high-risk cases like aerosol generating procedures. And that seems to be keeping us somewhat safe, which is good to hear.
Yes.
I would remind the audience that if they have any questions, please use the Q&A dialog box at the bottom of the screen, and we'll be fielding questions throughout this Q&A session. Dr. Bagdasarian, I had another question that came to mind as you were talking about immunotherapy, and obviously there are quite a few different immunotherapy and also other targeted therapy options nowadays for our cancer patients. And many of them harness the immune system and have interactions themselves. Obviously, in the recent few months, we've learned a lot about remdesivir, and that seems to be probably one of the few promising drugs out there for patients with active COVID disease. And I was wondering if there's any interaction or any challenges you've seen with people receiving these medications who may also need to be on immunotherapy or who have received immunotherapy and their bodies were primed for different immunological status.
Yeah, that's a great question. We don't know for sure, but yeah, we've done treatment with a variety of different immune checkpoint inhibitors. You know, they have different mechanisms of action. The mechanism of action of the immunotherapies is either towards the CTLA receptor site or the PDL1 or the PD1 receptor on the actual T cell. So there shouldn't technically, physiologically not be any interaction. You know, that is a good question. Thus far, I think we've had maybe one patient who was treated at the hospital for COVID that was, you know, receiving immunotherapy. That person had COPD, and he, God bless, he's done well. And you know, the couple slides, as I mentioned, you know, there's some discussion that the immunotherapy can increase the risk of infection, but that large study out of Sloan Kettering showed the opposite, and the authors felt that it offered more of a protection towards certain infections versus increasing the risk. But anyone who develops pneumonitis, which is thank goodness, an uncommon type of side effect, but if it does, you know, become quite significant, that itself can be life-threatening. And if somebody has COVID with that type of situation, then I can see, you know, catastrophes. But thank goodness the incidence of grade 3-4 pneumonitis is not that significant.
That's a very good point. Dr. Ghaffarian, do you have any questions to ask Dr. Bagdasarian?
Well, you mentioned that survivors are also at a higher risk with COVID-19. And you mentioned there are several factors. One of them is time from last treatment. What would you consider the length of time that would make a cancer survivor at the same risk as the general population?
Well, that's a good question. I think when let's take, for instance, the highest risk of individuals. Those are the transplant patients. Those bone marrow transplant patients, you know, their immunity sometimes never returns to normal, especially if they're on immunosuppressant agents to reduce the risk of graft versus host disease. Those are still in the, you know, a high risk category. Okay. Then there was, in the old days, we used to use very myelosuppressing agents and treatments like fludarabine for CLL that led to impaired cellular immunity for up to a year sometimes, you know, but we're no longer using such agents. So just looking at the patients with curative disease in the adjuvant setting, okay, that's, I think, the group that we should focus on. So, you know, if you look at the data, sometimes it takes up to 6 months to fully recover. And that all depends on the type of chemotherapy that they're utilizing, the age of the individual, if they've had radiation to the pelvis, individuals additional comorbidities, which all these things can compound. So if it's a healthy individual that received adriamycin cytoxan followed by Taxol, for example, in the dose dense, you know, that's a long treatment itself. Then they go through, you know, surgery. If in the neoadjuvant setting, they go through the chemo, then surgery, and then radiation. You know, these individuals may take a good 6+ months to recover in most cases. So, but yes, for the most part, if you're healthy, you know, within 3 months, in most, they should recover fully and completely. And this is where nutrition is so important. And there's so much data now. You know, in ASCO at the last several years, we've been seeing a lot of stuff on nutrition and the emphasis on how important it is to be well nourished, not only in the metastatic setting, but during adjuvant treatments, and especially in hematologic diseases. So it's a balance it's vital there, Arsina, that we need to emphasize in all our cancer patients.
Thank you.
Dr. Bagdasarian, we've had a couple of questions on a similar topic to the first one we asked. One of the other treatment options that COVID patients have been receiving, and our hospital has run some trials on this, and I know others have too, is the convalescent plasma exchange. We were wondering how, what information you may have on this, and maybe any updates on that, but also how would that interact in a patient who may be receiving other types of chemotherapy or IVIG or other types of plasma related treatment options?
Yeah, great question, Gurney. I think there's in the preliminary data shows some promise in that if it's, you know, the key is to recommend this to those patients who are, you know, the question is, should anybody who's asymptomatic, well, they looked at a subcategory, but the focus and emphasis in the trials were those who had symptoms. And the sooner you start the pheresis, the better off. And once they hit the cytochrome storm, then, you know, it's hard to reverse that. So, you know, this should be considered for those who are, for instance, immunosuppressed cancer patients, for instance, that have the COVID, that get hospitalized, that, you know, the elderly population, the high-risk groups, right? The cardiovascular patients, the diabetics, and the studies are promising. And I think that's going to be something to look forward to. We're hearing more and more data. I think individuals who are receiving IVIG, you know, you would like to hold off because of the possibility of neutralization of those, you know. If a patient's received IVIG, you know, maybe up to a month before, technically you shouldn't have an issue with that, but they may need more sessions. I don't know the answer to that, to be honest with you. But as far as the interaction with chemotherapy, you know, their immune systems are quite suppressed, so you're going to do your best to try to improve their neutrophil counts with GCSF and whatever measures you can take to improve their immunity during the plasma exchange. A lot of the patients for other diseases, you know, for Guillain-Barré and other viral associated diseases. I remember years ago at City of Hope when I was in training there, we had a similar situation like that in a transplant patient. And the patient was receiving rituximab, which is utilized for lymphoma. So we had to hold those treatments because of the concerns and dangers of not only further myelosuppressing that patient, but interaction. So I would think that it would be prudent and wise to hold those types of treatments during the COVID situation and pheresis.
So Salpia Karagian says hi and says it's a great presentation. Can you please tell us about CAR T-cell therapy?
So CAR T is a unique technology in that you're basically tweaking your immune system through manipulation genetic manipulation to home in on the cancer cells. And now the technology, in my opinion, is going to be such that in the next probably 5 to 10 years is going to replace transplant, because it's been shown to hold so much promise. Now, so to not only for, but now it's mainly for hematologic malignancies, okay? And it can be used in an older population of individuals and creating systems in place that will be safer. Because CAR T now, is generally reserved for patients who are younger and are in better shape, but they're now finding modified ways to administer the treatment over a sequential period in older population and achieving the same goal. So there's many centers of excellence that are doing research in that aspect. At the same time, perfecting the genetic manipulation, and at the same time now looking into using CAR T to go after solid tumors. So that technology is really still in its infancy stages, but it's holding a great deal of promise. And hopefully one day that will be open into the community hospitals where we can provide those treatments, in our backyard.
Great to know. Let's see. Are you aware of any indications that the FDA has changed due to COVID? In, let's say, drugs that were reserved for advanced cancers, did they waive those restrictions at all? Are you aware of any changes?
Well, the biggest problems we've been facing, we have a robust clinical trials, and the problems we've been having is enrolling our patients. The enrollment of patients in those trials have been delayed, and trying to bring on board some new trials have been on hold for now. And there's some promising trials that should have opened in April and May. Now they've postponed that until late June, July. So, but as far as the FDA approval, whatever was fast-tracked should not be, interfered with, and that approval should be coming up. So there may be some delays with accruing patients. This has been a big issue. So we'll see. Now things are opening up, and I'm hearing more and more from our one of my partners, who's the clinical trials director, that by the end of this month, we should be up to 80–90% enrollment.
Okay.
Stop me if this question was asked, but I just got back on this question and answer session. Question from one of the members from Avo Artinian regarding delaying chemotherapy. Was that question already asked? No.
Well, delaying chemotherapy, I think we discussed it briefly. Dr. Artinian is a great surgeon, a friend of ours. The delaying chemotherapy for patients with advanced disease, especially if they have curative disease, is not wise. Doing neoadjuvant chemotherapy is vital because you could downstage these individuals to possibly go through a curative surgery. Delaying chemotherapy in patients with advanced disease on the other end of the spectrum is not wise. You have to look at the risks and benefits. How old or young is that individual? For the most part, delay is not wise for neoadjuvant patients and for patients who have advanced disease.
So does the status of the COVID test make a difference? So if the patient is COVID positive, does that change how you handle chemo?
Yes, and it all depends on the immunosuppressant. If they're asymptomatic patients, and you're going to embark on a very immunosuppressive type of chemotherapy, such as in advanced lymphoma or in a patient with acute leukemias, you want to delay that. We've postponed doing induction chemo in acute leukemia that have infection because otherwise you're putting gasoline on the fire. So if it's not a very immunosuppressant agent and the patient's asymptomatic, and these are oral targeted treatments, for instance, then perhaps that may be something to consider. If they're on a trial of immunotherapy, that may be okay to continue, since ASCO didn't really identify a major risk for that. But you have to be very careful and very selective in who you recommend those treatments to.
Okay, great. Good to hear. I think we addressed that question. A separate question now, maybe moving out into the outpatient world. You know, certainly the hospital has been impacted, but also clinics have been impacted with the ability to see patients. And one of the questions is, with regards to screening patients, you know, their typical 1 month, 2 month, 3 month screen, they come in for PET CT or whatever. How are you handling that? Are you using virtual platforms to keep them out of the office? And are there any precautions made in an oncological setting that may be different from a typical ambulatory setting?
Yeah, that's a great question. You know, again, to get the patients to come to our office, we had to basically walk them through the steps of what we do, you know, pretty much aligned with like a mini tertiary care center, and the pre-screening and the safety net that we create in the waiting rooms as they walk into the office, the different levels of screening, you know, and to secure these patients. Now, the diagnostic centers, you know, many have done the same. The hospitals are doing similar. They test patients before they bring them in. But for the most part, for screening, you know, to go to a diagnostic center, you send them to one that you trust, and that have championed that, and to create that sense of comfort. You know, patients with BRCA mutations or with high-risk Lynch syndrome, you know, if they were scheduled for a colonoscopy in, you know, March, and now that's been delayed 3 months, they need to proceed in getting that testing. The high-risk patients need to be tested. The high-risk lung cancer patients that typically go through a lung cancer screening where periodically a CT of the chest is important. You know, those patients, we spend a great deal of time on teleconferencing, educating and explaining to family of those to reinforce what we're saying in Armenian, in English, and so it took you know, quite some time, Garni, over the past several months to create that comfort zone for a lot of patients, and now we're seeing the patients come in more and more, and we've pretty much the time that we spend in doing teleconferences is still important. People who are immunocompromised, you know, we want to get on the phone or to Zoom conferencing with them and see how they're doing. If there's concerns, you need to address and you know, extinguish everything immediately and not allow things to escalate. So this has been something that our whole group has been doing. You know, our infusion hours are much longer now, Garni, because we have to space our chairs. You know, we have a distance between each chair.
Yeah.
Normally we would infuse in about you know, in about 2/3 of a day, now goes to, you know, well over a full day, and our infusion nurses are there till like 6+, you know, 7 o'clock sometimes. So but this is how it's going to be for you know, at least in my opinion, probably until next year, until a vaccine is out and until things cool off.
Yeah, I think those are all really great points, Boris. And I'll tell you, seeing some of the challenges our patients have been facing, I've seen patients, as you mentioned in your lecture, delay care because they're afraid of the virus. And then they show up with what may have been a treatable cancer and maybe now is not as treatable and is metastasized beyond the capacity of treatment. We've also seen patients who are not willing to travel, you know, if they need to go to a place that has a specialist, but they're afraid of getting to a more congested area. I've had a couple of patients who were delaying surgery because of the visitation policies, meaning that because they were not allowed to bring a family member in, particularly with younger patients whose parents are still involved, even if they're past the age of 18, it has been an issue. And these are all struggles that are, I think, unique to the COVID situation, which we haven't faced before. And I'm so glad, Boris, you mentioned the multiple hats you wear as an oncologist, where you're not as much, well, you're not only performing oncology, but you're also performing nutrition and primary care and pain management, and more importantly, probably psychology, psychiatry. And I'd love to hear a little bit more about that. You know, we obviously seen a lot of challenges from a mental health perspective, the stresses of just dealing with social distancing, but also on top of that, compounded by a challenging diagnosis. How have you approached that? Are there resources out there that other practitioners can use to help take care of their patients with this? What's a good strategy for these?
Yeah, Garni, thank you. You know, before COVID, we were pretty much doing that to begin with, because as an oncologist, you know, we're not only treating the cancer, we treat the person as a whole. And this is the philosophy of our group. And we have a team, you know, we have nutritionists, we have we try to do our educationing with pharmacy, with nursing. And so it's a team effort. It's always been that way. This is the success that you have to have a team to succeed. But more importantly, you know, they want to hear from the doctor. And so, you know, you got to hold the hand of the patient through the whole experience of the cancer treatment. And during these tough times, to, you know, get on the phone, and they see you, they trust you, they care for you. And when they hear your voice, it's a very soothing, comforting thing for them. And that goes the same for all my partners, you know, who treat Hispanic, Armenian patients, Korean patients, Russians, you know, Farsi, you know, Caucasians, Americans, etc. I mean, it goes a long way to call and, you know, just drop in a call, see how they're doing once or twice a week. You know, it's important. In the past, we used to get calls on the weekends. You know, I tell them to get on a Zoom conference if they can, because it's kind of difficult for Armenian patients. But, you know, when they hear your voice on the phone, that goes a long way. And so it's in the beginning, you know, at the height of this, you know, scare, where is this going to go? You know, what's my situation going to be? Are we all going to die? Everyone was frantic. Everyone was so scared. And you know, it took a lot of energy, took a lot of effort, but globally together, we succeeded. And, you know, working with your PCPs, and that's another key thing. So, you know, when you have good doctors that you work with, it's complementary, you know. The psychiatrists are already they were busy before COVID. So, you know, you got to have the ability to balance things and know when it's right to prescribe certain things. You know, you talk through them, to explain things to them. When is it right to prescribe? When is it right to, you know, perform other things? So you go through the A through Z's in terms of managing everything to relieve anxiety, stress, you know, not seeing your family member, seeing them through the window. It's very stressful. It's very stressful. So when they see the doc, talk to them, or the nurse, you know, it's very soothing for them. So this is a very important aspect that we've emphasized greatly, and we have once or twice a week meetings with everybody, and we're a big group. And this has been emphasized almost all the time, and how to perfect that. So it goes a very long way.
Would you say that due to COVID, actually, have you experienced a decrease in the number of infections, non-COVID related infections, because of all the precautions that we're taking?
Yeah, and I think we're going to see that this year that maybe the outbreak of the flu is going to be significantly better because of that, because people are now in tune, washing their hands, avoiding touching their face. And I agree. That is because of the reinforcements of social distancing, washing hands, wearing a mask. Absolutely. I agree, and I hope this continues for a very long time, and that people don't forget, even when COVID's thing of the past.
Well, I was referring more to febrile neutropenia cases, infections due to immunosuppression.
The immunosuppression, we've been very good about reducing the risk of hospitalizations. Health plans love us because we keep them out of the hospital. But at times you might need to overuse these growth factors to reduce the risk of hospitalizations. And so our hospitalizations have been low before COVID, and now that the threshold is at a point where you can initiate the use of GCSF or Zarxio, Neupogen, Neulasta, in some of the intermediate ones that you normally would wait until their counts are down, it goes a long way. I mean, these are precautionary things that we firmly believe in, as making phone calls, making sure that they're fine, that they're social distancing. These are things that we educate the patient and family members, even before COVID.
So are you injecting Neupogen at patient homes, or is it?
Yeah, we try to do our best to try to get that, dispensed to where home health can go out and do the injections. If they have a caregiver or a family member who's a nurse or who knows how to inject, some patients feel comfortable injecting. Absolutely, we do our best to try to do that. And like I mentioned before, if there are oral agents that provide the same response, like Velcade and Ninlaro for myeloma, for instance, then, or Revlimid, that's the thing you would recommend for these patients.
Mm-hmm.
Boris, I want to take this opportunity, particularly as this is also being broadcast on Facebook, to just make one point to reiterate. It's been Memorial Day weekend. There have been the protests. I've seen a lot of people outside without face masks, completely ignoring social distancing. And I have to reiterate to everybody listening, to all the physicians who are there or practitioners there who have the opportunity to talk to their patients, to remind them to keep wearing face masks, to keep the social distancing going as best as you can. I know we're reopening the economy and that's important, but at the same time, we learned from the last genetics webinar that we held that as the social distancing goes down, the virus becomes more potent, more virulent. So this is our opportunity to talk to our patients and remind them. And when you see them not wearing face masks, just tell them, hey, you got to play your part, and including the family members and everybody around. I have colleagues who are recently becoming positive for COVID, and so it's still a very active issue, and we shouldn't just relax just because the government is relaxing. So I just wanted to say that as we're wrapping up.
No, 100%, Garni. I think you hit it on the nose. This is really serious. We cannot put our guards down. This is vital. We reiterate over and over to all our patients. Thank God, a vast number of our patients are compliant with our recommendations, as are their family members, and they're very careful in avoiding communication with these individuals. But we're going to see an increase the next several weeks, unfortunately, because of this. And not only here in LA, but throughout the whole country, and in some parts of the world that now are protesting, like in London and Paris.
Yeah, it's all happening.
It's important to get the word out, but this is a serious disease. We have to be very careful in how we approach this. Crowds and people not wearing masks, and it's very concerning.
Thank you. One final question, Boris, before we wrap up. This is also from Dr. Akaragian. She did mention something and goes back to the psychological aspects of healthcare and oncology delivery. She notes that oncology patients find support groups very useful. How is this handled during the pandemic? I realize there are virtual connections. Are there other innovative ways to address this need?
Yeah, great question. We have support groups in Glendale. We have an Armenian psychologist that runs it for our Armenian patients through the Adventist at the Cancer Center. So everybody's been trying to get on Zoom. You know, we've been trying to tell the or educate the family members to try to do their best to download Zoom, show them how to use Zoom, and set it up for them so they can conduct these things. They're accustomed to Skype, but Skype is, it's not, regulated properly. So they have to abide to the Zoom platform, Teams perhaps, but we've been talking to them about that. And this is where the lack of these, type of support group conferences, which took place once a week now, is barely at a monthly situation. So we're reaching out to the Cancer Center to try to make these calls, try to get these people on the Zooms, and maybe divide up the group, in several different sessions. That's probably what you need to do throughout the whole day, and to accommodate for everybody. Mm-hmm. But that's a good point. That's a excellent means of ameliorating the stress, and those support groups that we refer patients to serve an amazing role and purpose.
Good to hear. Yeah. So just a couple of closing notes before we wrap up. So first of all, I just want to remind the viewers that for the physicians, there will be 2 CMEs available for this session, and for the dentists, there'll be 2 CDEs available. You just need to visit our website and complete a post-webinar activity, which is basically a short quiz, and you'll be awarded the CME credits. Also, a reminder that we will have 2 very excellent webinars on Monday and Tuesday, June 15th and 16th, and I encourage all to attend as I find these equally very educational and helpful. Finally, I'd like to thank Dr. Bagdasarian for your time and knowledge and expertise and spending your Monday evening with us on this important topic. To Dr. Galfayan and Dr. Sepilian and the rest of the CME committee, thank you so much for your organization. To Hasmik, who has really put this all together and keeps Medical Society running, and to all of our members who have been paying attention and who keep making the Medical Society very successful. Thank you very, very much, and hope you all have a great evening.
God bless you.
Yeah, God bless you.
God bless you all.